As far as New Yorkers are concerned, 1/4 of our tax dollars are going into medical services.
Yes.
Largely in the form of Medicaid. We think of Medicaid for the poor and disabled, which should be 1/6, 10 to 15% of our population, but now it's serving 1 in 3 statewide, and in New York City, many estimates 1 in 2.
And many of those people have jobs. Most of them are not disabled. They are generating income. They have some ability to pay for their own insurance, but they're enrolled in Medicaid, which is no cost. The taxpayers are paying the entire cost. Whatever the reasons are, it's changed the nature of Medicaid. It's now become kind of a catch-all insurance plan for people who don't have other insurance. This has been a chronic issue, not just in New York, but all over the country. So to the extent there's a crisis, it's not driven by anything that's changed in Medicaid. To the contrary, Medicaid has been increasing its effort. But it remains lower than the other insurers, and so that becomes an arguing point for the industry. You're underpaying us, and it's unfair.
Hello and welcome to New York Insider. I'm Liam O'Neill, and today I'm seated in Albany, in the state capitol. And sitting across from me is Bill Hammond. Bill Hammond, you are a fellow at the Empire Center.
That's right.
You have a journalistic background, and you are, by many, considered an expert on health matters.
To some extent, yeah.
To some
I try
extent.
to be.
You're somewhat humble, though. Can you tell us a little bit more about your background? Today we are going to be talking about health, largely. So tell us a background that is relevant for our audience.
I spent most of my career as a newspaper journalist, first as a straight reporter at local newspapers, and I gradually made my way to the Daily News, the New York Daily News, and I was an opinion writer for them based in Albany. So I focused on state politics and policy with respect to New York City in particular.
Okay.
I left the Daily News in 2015 and joined the Empire Center shortly after that. And at the Empire Center, I focus on healthcare, but still at the New York State level.
Okay. So healthcare is an important matter. Last week, the budget finally passed. And I think by most measures, healthcare is the biggest item in the budget. If you go on various government websites that give us insight into the budget, it's, what, 30% or 40% of the budget?
I mean, I guess it depends on how you slice it. The overall Medicaid program, which is the bulk of healthcare spending, is just over $100 billion out of a $230-something billion budget. So if you look just at the state-funded part of the budget, it's about, it's a little over 25% of state funding.
Okay, because a whole bunch of money from Medicaid comes from the federal government.
That's right. Yeah, about just over half of the money comes from the federal government.
Okay. But as far as New Yorkers are concerned, 1/4 of our tax dollars are going into medical services.
Yes.
Largely in the form of Medicaid.
Yep.
That's a big deal. It hasn't always been that big. I think it's one of the fastest growing parts of the budget. Is that correct?
Yeah, yeah.
Can you give us a sense of how much it's grown?
Well, just in since the early 2010s, it's about doubled from what it was then. But there's been a real burst of growth since before the pandemic. The last 4 years, it's grown by about a third, 35%, something like that.
Wow.
So it's been growing percentage-wise at a double-digit rate for the last several years. And there was a real change when Governor Hochul took office. She was lieutenant governor under Andrew Cuomo. Mm-hmm. He resigned, she became governor, and then she won her own term in an election. She's now presided over 3 budgets, and in those 3 budgets where she was kind of the primary author, the first 2, there were double-digit increases, and then the one that just finished up was a smaller increase because she made I think she realized that the rate of growth was unsustainable. She said as much in January, and so she made a real effort to put the brakes on it this year.
Mm-hmm. But still, it's grown by about 30% in 3-4 years.
I mean, there was a big disruption during the pandemic, which kind of throws off all of the comparisons. So I've been using the period just before the pandemic as a benchmark. And since then, which would have been, in terms of fiscal years, it would have been fiscal year 2020. The budget we just passed is fiscal year 2024. And during that period, it's grown by a little more than a third, somewhere between 35 and 40%.
That's a lot.
Yeah, it was quick.
That's really a tremendous amount of growth. And a whole bunch of questions come to mind. How is the level of healthcare grown in that time? Positive? Negative?
Well, so our population in New York State has been pretty stable. So it's not because of a growing population. In fact, in some years we've lost people.
Yeah, actually, I mean, I think many estimates, that we've lost a couple 100,000 people minimum over 4 or 5 years.
It's funny because the census comes
we've
out,
lost a congressional seat.
Yeah, and that's because our growth relative to the rest of the country was stagnant. So it wasn't because of population growth. During the pandemic, there was a surge in demand for Medicaid, but that ended pretty quickly. And right now, enrollment is declining, so it's not because of a growth in enrollment. Some people have said, well, our population is aging, and that does affect Medicaid because older people tend to enroll in Medicaid and they need, in some cases, very expensive services. But the spending on that portion of Medicaid has grown about 10 times faster than the population growth and the over 65 population growth. So really what has happened is that lawmakers have just decided to be more generous with the healthcare system, not because of population growth, not because of rising demand, just because of demands from the hospitals and the nursing homes and the other components of the healthcare system. They have been beating the drum for higher reimbursement under Medicaid, and the legislature has agreed to do it. So it's been, the healthcare system is the most influential interest group in Albany. They have...
It's a powerful lobby.
They have, it's a big business, healthcare. Hundreds of billions of dollars are spent on it every year. And therefore they have lots of resources to spend on both lobbying and also campaign donations. And they use those tools very skillfully, and the legislature is usually very eager to satisfy them, at least not to aggravate them. And so this year...
There are political consequences.
There can be, or at least the legislature believes that there can be. This year, many New Yorkers would have seen TV advertisements sponsored mostly by the hospital industry, but also by the nursing home industry, where they portrayed Medicaid as being in a crisis. They portrayed the healthcare system as being in a crisis. And they said the blame for that was on Medicaid not paying enough, and the answer was a big increase in Medicaid, and that's what they got.
So Bill, you've told me two things that seem to be incongruent. There's a 30% increase on the one hand, but on the other hand, Medicaid folks, people in that industry, are saying there is a funding crisis?
So New York has the most expensive Medicaid program on a per capita basis. We spend more per capita than any other state. So it's by the standards of Medicaid, it's a very generously funded program. And in just the past few years, we've seen spending on the program increase, as you said, by about a third. So to my mind, there's no new crisis. I think what the industry would say is that Medicaid, of all of the different health plans that are out there, Medicaid tends to pay the lowest rates. Commercial insurance pays the highest rates. People who have jobs that come with health insurance, those plans tend to pay the best reimbursements.
Right.
Medicare is below that, and then Medicaid is either near Medicare, maybe a little bit lower than Medicare. And so this has been a chronic issue, not just in New York, but all over the country. I would say New York, as I say, New York has a more generously funded Medicaid system than most states, and so that is reflected in the rates that it pays. They're probably more generous than most states. And as we've said, they've increased recently. So to the extent there's a crisis, it's not driven by anything that's changed in Medicaid. And to the contrary, Medicaid has been increasing its effort. But it remains lower than the other insurers, and so that becomes an arguing point for the industry. You're underpaying us, and it's unfair. As I say, I don't think to the extent that the healthcare industry is struggling right now, it's not because of anything that's happened in Medicaid. It's because of other structural things that are going on. There's a lot of consolidation happening in the hospital industry. Nursing homes just went through this enormous crisis of COVID and tragically lost thousands of their residents. And by the way, people are much more reluctant to go to nursing homes now. So the demand for nursing home services, which has been declining, really took a dip since the pandemic. And so there's all these buildings that were built to hold 200 or 300 people, and they right now only have 100 or 100, like they're way under capacity. On top of that, during the pandemic, some healthcare workers, they gained a lot of leverage in terms of the amount of pay they could demand from their employers, and so pay has been increasing. It's also been harder to recruit some kinds of healthcare workers for some kinds of jobs. The overall number of healthcare workers is as high as it's ever been, but it's harder to recruit people to work in a nursing home, for example. So all of this has kind of stirred together to cause areas where there is what could be called a crisis, a shortage of workers. It's not industry-wide. As I say, industry-wide, we have more workers than ever. But the industry is very skilled at highlighting those places where there is a shortage of workers or where there's a shortage of funding. They make it in their lobbying and in their advertising, they make it sound as if it's an industry-wide issue, and they make it sound as if it's entirely Medicaid's fault. And they use their influence in Albany to sell the idea that the answer is a big increase in Medicaid funding. And then ironically, the biggest increases go to hospitals, smaller increases go to nursing homes, and then the smallest increases of all go to the workers who serve the disabled.
So the money that is allocated for Medicaid at the New York State level, $100 billion odd dollars, it does not follow the patient.
Not always, no.
But rather it keeps afloat, correct me if I'm wrong, hospitals that would otherwise be failing, or nursing homes that would otherwise be closed. Is that correct?
So a large portion of Medicaid is about reimbursing the bills that are incurred by Medicaid recipients. So when the Medicaid recipient goes to the hospital or goes to a doctor, goes to a nursing home, they generate an expense. The nursing home or the hospital sends a bill to Medicaid, and Medicaid pays it.
So that's an example of where the money is following the patient.
That is following the patient.
Okay.
But then on top of that, Medicaid has an awful lot of spending that goes directly to the provider in the form of discretionary grants. And that is, sometimes it's supposedly paying for quality improvement or training or some other healthcare priority, but often it's just general operating support, a general subsidy. And in some cases, hospitals have become dependent, and nursing homes have become dependent on that funding just to stay open. They're operating, maybe they've lost patients in recent years. Maybe they've had their patients take their business to another institution, so their income is down. They have not adjusted to that loss of income. They've not sufficiently downsized their expenses and their staff. So they're running at a loss, and the state comes in and says, okay, we'll cover that loss for you and allow you to continue running at a loss with our help. And so that's another big portion of what Medicaid
Okay.
spends on. Often has nothing to do with providing care for a patient. It's just an operating subsidy.
Now, in defense of that type of decision that is made, could you put it this way, that New York State is very lopsided. We have a lot of wealth in New York City and around, and a lot less wealth in the 100 miles, north and west of the city. And so you have these situations, these vast rural areas that maybe only have one community hospital. It's losing money, but if that were to close, that would be affecting people in a 50-mile radius who would otherwise not have any health care.
Well, I guess I should point out that there is a considerable amount of poverty within New York City itself. So like there's super wealthy people, and there's also a sizable population of low-income people. But as you say, there are hospitals upstate where their population has diminished. So, and the demand for their care has diminished. They find it difficult to make ends meet with the reimbursement that they have. And to some extent, the state is propping them up with subsidies. But an awful lot of the subsidies go to hospitals in New York City as well. It's not just upstate.
Okay.
In fact, the largest dollar amount of subsidies goes to Brooklyn.
Is that right?
Now, Brooklyn is, as I just said, it's one of those places where there's a concentration of wealth, but also of poverty.
Sure.
And
well, it's a place where you
there,
also have a shrinking middle class. I mean,
well, the whole city has that trouble.
That has that trouble
because it's so hard to find affordable housing. But in Brooklyn, you have, I think one of the big problems for hospitals there is that they're right across the river from some of the most famous hospitals in the world. NYU Langone, New York Presbyterian. And so if you live in Brooklyn, when it's time for you to have a high-end surgical procedure, you might very well decide it's worth it to go across the river, maybe a half hour, an hour away.
Right.
Get your surgery there because you feel more comfortable going there. Whereas when you have an emergency, you go to your local institution in Brooklyn. And so that's difficult for the Brooklyn institutions to manage when all they're getting is kind of the emergency work and the low-end hospital work, and all of their customers are going for their high-end work are going elsewhere. And that's part of the problem. Brooklyn lives in the shadow of Manhattan. Queens and the Bronx have the same situation. So that I think that's a structural issue in the hospital network and the hospital system that we haven't fully grappled with.
Wow, a lot of nuances here. When you're talking about Medicaid, mission creep comes to mind. Medicaid is for the poor and disabled, and yet we have, I think, 1/3 of New Yorkers on Medicaid, and in the city, 1/2. Is that correct?
Roughly, yeah. So
that seems like a mission creep.
One form of mission creep is what we just discussed, where instead of just reimbursing for patient care, Medicaid has taken on this job of subsidizing money-losing institutions. But then the other form of mission creep, the other big form, is the expansion of who's enrolled. As you say, the shorthand for it used to be it's for the poor and the disabled. People who can't pay for their own insurance because they have no income, often because they're disabled.
In this discussion on Medicaid, the term mission creep comes to mind. We think of Medicaid for the poor and disabled, which should be, what, 1/6, 10 to 15% of our population, but now it's serving 1 in 3 statewide, and in New York City, many estimates 1 in 2.
This is something that's quietly happened just in the last 10 or 15 years. It used to be that Medicaid, the shorthand for it was for the poor and the disabled. And the idea was these are people who can't possibly pay for their own health care. In many cases, they're too sick to have a job, or maybe they have a drug addiction issue or something else. Maybe they're mentally disabled, something that prevents them from paying for their own health care, and yet they have severe need for health care. So that's what Medicaid was supposed to do. And so traditionally, Medicaid enrollment would more or less track the poverty rate. Starting around 2011, those two numbers started to go the opposite direction. The poverty rate came down.
And excuse me, is this statewide or nationwide?
Well, it's happening nationwide to some extent. I've mostly focused in New York, and I feel like the divergence has been more extreme in New York. So the poverty rate was declining. It's now currently it's maybe 15%, 1 in 6. But the enrollment rate in Medicaid kept going up, and to the point where more than half of the people enrolled, as of 2019, more than half of the enrollees appear to be living above the federal poverty line. And so, and many of those people have jobs. Most of them are not disabled. They are generating income. They have some ability to pay for their own insurance, but they're enrolled in Medicaid, which is no cost. The taxpayers are paying the entire cost. And I'm not exactly sure how that's happening. I think it probably has to do with the fact that the enrollment standards for Medicaid have gotten more lax, partly because of the Affordable Care Act. And also Medicaid has kind of intentionally expanded into, so for example, if you're an expectant mother, you're entitled to Medicaid at a higher income level than the standard level. But the result has been that
That's one example, but you're not sure of other examples that have allowed this over-enrollment to happen.
No, I mean, it's a little bit of a mystery. It's something that I'm doing some research on. I think other people have highlighted this disparity where if you look at the census has data about what people's incomes look like, and the census is saying, 15% of your population is below the Medicaid eligibility line, and yet 33% of our population is enrolled, or in 40, or in New York City's case, close to 50%. But whatever the reasons are, it's changed the nature of Medicaid. Yeah. It's no longer primarily an insurance plan for the poor and disabled. It's now become kind of a catch-all insurance plan for people who don't have other insurance. And I think that distracts from its original role. So we were just talking about the different reimbursement rates. The people who need Medicaid most are the mentally disabled, the mentally ill, people with drug addiction, and the super poor, the indigent. Their healthcare needs often involve things like group homes and occupational therapy and physical therapy and mental health therapy that's not provided by hospitals. And yet, when the Medicaid budget is being drawn up, hospitals are usually at the front of the line just because of their lobbying clout. And they often get rate increases that are larger than the rate increases that are given to those group homes that specialize in dealing with the disabled. And to me, that's like a sign of mission creep. You're increasingly focused on the less needy, the less disabled enrollees, and less focused on the original core population that Medicaid was supposed to serve.
Wow. Well, that is, I hate to say, I mean, for lack of a better term, that's a damning indictment of this current situation, that Medicaid has originally started with the intent of helping the poor, the mentally disabled, whatever, people who just are in dire straits and need this, but yet with this increase in enrollment, they're the ones who are less served. Is that what you're saying? I mean, because these big powerful lobby entities they're sucking up the money, and it's going towards in the opposite direction. That
is the danger of what I'm talking about. That it'll harm the most vulnerable people.
Jeez.
Now, I think part of what happened was the Affordable Care Act, which set as a goal trying to get close to universal coverage. And it had two principal tools for doing that. One was expanding Medicaid to technically 138% of the poverty level, just above poverty.
Okay.
The other tool was to subsidize private insurance for people in the lower middle income and lower income range.
Okay.
So if you were up to 138% of poverty, you're supposed to get Medicaid, and then above that, you're supposed to buy an Obamacare plan with help from tax credits.
Got it.
And so it became, that became the priority of a lot of people in government, especially in New York State, which is a blue state. So they stopped thinking of Medicaid as something to avoid, and they started thinking of growing Medicaid enrollment was a sign that we were making progress towards universal coverage.
Got it.
And in fact, the state did get closer to universal coverage. We're right about 95%, which is historically the highest it's ever been.
Okay.
But a lot of that was achieved by expanding Medicaid. Very little of it was achieved through Obamacare plans. And there's, just to complicate things further, there's something called the Essential Plan, which is kind of like an add-on to Medicaid. It starts at 139% of poverty, goes up to now 250% of poverty. So there's another band of low-income people who are getting taxpayer-sponsored insurance through the Essential Plan. And that's leaving very little room for commercial insurance at the low end. And I think compounding this phenomenon is the state's overall posture towards commercial insurance, which is to regulate it very heavily.
I see.
They're not focused on the cost. They're entirely focused on what it covers, and they put increasing mandates on what it has to cover. And that drives up the cost, makes it harder to afford, fewer, to some extent, employers. You might expect employers would want to offer health insurance, but it's so expensive that they often decide that they can't. And so that increases this trend of more and more people slipping into
Medicaid.
the taxpayer-funded system.
Got it. So it's harder to insure in the state as a private.
It's more expensive, and and therefore, harder.
Okay, so here's an essential question that should be brought up in this discussion. As the amount of money has increased dramatically, how has the quality of health care responded?
We don't have great quality in our healthcare system, at least not consistently. One area that I look at a lot is hospital quality, because they're kind of the flagships of our healthcare system, and they get the lion's share of the funding. And the federal government has a report card for hospitals. They give each hospital a star rating from 1 to 5. And we do have a handful of hospitals, very high profile, famous hospitals, that get 4 stars and 5 stars. But if you look at all hospitals and you take their average star rating across all hospitals in New York State, it's about 2.5 stars. And it's a mediocre grade, and it turns out
how does that measure against the 50 states?
It's one of the lowest. I mean, it's probably somewhere around 44th or 45th out of the 50 states. So here we are, we're spending the most money of any state, but we're getting
by quite a bit.
Well, on Medicaid we're spending the most. Overall, we're probably spending the most. That's harder to measure, but we're a very high cost state.
Yeah.
And yet our quality is not commensurate with the amount of spending that we're doing. And I think both of these issues have a common political ingredient. And that is that the influence of the healthcare industry is so kind of overwhelming that it's very hard for people in the legislature or even people in the executive branch in the health department to stand up to that kind of political clout. So if a health commissioner was to call out hospitals for their quality issues, they would probably face political pressure to back down. And so the term of art is regulatory capture. I think there's a certain amount of that in our state government, that the healthcare industry has the power to help people get elected, They help governors get elected, they help members of the legislature get elected. And so once they're in office, they don't want to bite the hand that feeds them. And that translates into a lot of focus on more money for the healthcare industry and not a lot of focus on regulating them and demanding more higher quality.
Okay. Bill, this has been a very nuanced conversation about healthcare that I don't think a lot of people know about. You are just a wealth of knowledge, and I want to thank you for coming on the show and shedding light on this. I'd love to have you back another time because it is such an essential part of New York State in our expenditure and everyone's lives, healthcare. So once again, thanks for being on New York Insider.
Well, thank you for giving me the opportunity.